Hello and good morning. I'm going to be doing case studies with you guys. I'm just going to go through three different patients. We have time to go through what are my thoughts, what am I thinking as I work through different patients. Our first patient today is Miss Johnson. We are going to work through her approach to care. So she's presenting to the primary care clinic. She's a 65-year-old female. She has hypertension, type 2 diabetes, and hyperlipidemia. So a lot of our consistent diagnoses that we're seeing in our comorbid and elderly patients. What is her presenting complaint today? Why is she coming to us? That's where we start. That's where our focus is. She reported several recent elevated blood pressure readings at home. So what are some of the first things that we're really going to want to ask a patient who is presenting with changes in a chronic disease that they currently have? We're going to want to be thinking about, has there been any changes in her medication? Is she adhering to her regimen? Has she had any changes in her diet? Has she recently traveled? Has she been just any changes in her day-to-day life and her daily activities that would warrant her blood pressure to increase? And when we asked Miss Johnson some of these questions, we discovered that she is adhering to her prescribed medication regimen. She does not have any other additional symptoms. What are some additional symptoms that we would want to immediately ask about with elevated blood pressure readings? We always want to make sure we are looking at and ruling out our red flags. We want to think, okay, are you having any changes in vision? Are you having any severe headaches, dizziness, syncope, or near syncope? We want to make sure that we're looking out for like hemorrhagic stroke symptoms, chest pain, and all that. She denies any new symptoms. She denies any changes in her daily activities. We do a 24-hour diet recall. There's not been an excessive amount of sodium. Sometimes it's just that they recently maybe went to a restaurant. I'll find that they'll either go on a vacation or they'll have been to a restaurant the night before, present with higher blood pressure than normal. Might feel a little funny or different. They'll present for that. What's her blood pressure on today's reading? It's 158/98. She reports it at home. It's typically been in the 130s uh, until the last week or two. She's started seeing 140s, 150s more consistently. And she said, yes, over the last 2 or 3 months, it was slowly creeping up. But once she started seeing some consistent 150s this week is when she really became concerned. So she presents with those symptoms. Her heart rate's 80 beats per minute, rest 16, oxygen 98. On her physical examination, you can do a focused examination here. But when you think about cardiovascular, you think about all of the different areas that it really does affect. So you're going to listen to their lungs. You're going to listen for any fluid on the lungs. It's going to be clear on auscultation for this patient. Of course, listening to the heart, you're feeling peripheral pulses. You're looking for any signs of edema. And all of that was normal, regular rate and rhythm, no murmurs, no swelling, pulses were nice, +2s, and checking out that abdomen as well. You're looking for any other reasons why her blood pressure might be elevated. Is she ill? Is there some other secondary cause? The soft, non-tender, non-distended, no fevers, no gross discomfort, no neurological deficits. So the only thing we're really finding on this exam, as we're thinking about and ruling out all of these different red flags, is we've had a slowly creeping up blood pressure. So one important thing is to see if they haven't done their blood pressure logs and ask them to present those. And like I said earlier, she gave us her verbal blood pressure log, but we want to encourage our patients to be writing it down and bringing it with them. It's very helpful to watch and see the trend. And her trends were reflected in this blood pressure log. It really did look the same. It was 160s, or sorry, not 160s, 140s, 150s, slowly creeping up until the last week or so. It's a lot of 150s. What kind of testing could we do? What kind of labs do you want straight away for a patient like this? We can go ahead and get a CBC. Would be warranted if she hasn't had one recently. We can get a CBC, check out those kidneys. So we're checking the kidneys, the renal function as well. All of that came back normal. CBC is clean. Urinalysis is also a very kind of quick and easy way to check out the kidneys without having to do a CBC. Just do a point of care urinalysis looking for protein or blood. And her urine was also clear. So it really depends on what your resources are, how recently they've had other labs as to what you want to do. But a very cheap and easy way to check kidney function is to ask for protein and blood in the urine. You can also get the CBC and the kidney function just to check everything out. Fasting blood glucose was 160, a little elevated, not surprising for this patient. She does have type 2 diabetes. Her A1C, though, has historically been okay. We're not trying to address that or assess that today. The lipid panel, elevated LDL, again, expected. She has that as well. So, what kind of medications is she currently on? Let's review her current meds. She is currently taking 5 milligrams of amlodipine. That's what we've had her on. She's also on metformin, 1,000 milligrams twice a day. She's on a statin every evening. So we've got all our medications covered. Uh, with our diagnosis for this patient, what are we going to think is going on? You could think uncontrolled hypertension, suboptimal medication adherent, is it white coat, or secondary due to another condition. In this case, we ruled out that it's an adherence issue. The patient does attest to taking their medication and doesn't seem to have a reason to lie. Has been with our practice for 5 years and has never had an issue. White coat hypertension we ruled out too because it's not remarkably elevated. I'll see white coat hypertension is 160s, 170s with a history of normal blood pressures at home, but we have her law. We've seen that it's going up slowly with the secondary hypertension due to uncontrolled diabetes. It's not uncontrolled diabetes. I would say more it's in the setting of diabetes. So uncontrolled hypertension in the setting of type 2 diabetes mellitus would be an appropriate diagnosis. So what do we need to do? We need to review their medications. We need to think about any lifestyle modifications, just going over everything again. You'll be surprised that when you start digging, you'll find little things here and there that they might not have thought about, getting lower sodium alternatives at the grocery store, things like that. So what do we do for this patient? We're going to increase her amlodipine from 5 milligrams to 10 milligrams and see her back in 2 weeks. Make sure that she continues to take her blood pressure. Review again how to take blood pressure at home. They need to be, your nurse should be doing this, or you should be doing this, making sure that the patient's sitting with their feet flat. Or usually we want them sitting and resting for about 5 minutes. Not walk, 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 sit down, take blood pressure immediately like we do in the doctor's office. We need them to rest for a few minutes, sitting, feet flat, take that blood pressure. That's why if I have a patient whose blood pressure was remarkably elevated by the MA when they came in, I will typically just slip the cuff on after we've been chatting casually for a few minutes and just retake it. Or I'm trying to find a moment where I'm not too stressed out. I built that rapport and they've been sitting still for a little while. We can go ahead and get another blood pressure and verify what that blood pressure might actually be. And of course, do a manual. At home, they're using their automated blood pressure cuff because it's remarkably difficult to take blood pressure on oneself with a stethoscope if you're not medically trained. We also want to discuss the importance of the adherence and the side effects you might want to see. So reviewing the side effects with amlodipine. And again, we want to follow up with 2 weeks to see how that blood pressure is doing. So when she returned after the 2 weeks, she did have improved blood pressure readings. It was 130/80. Her sugars over the past couple of weeks have been sitting more in the 120s. She sort of paid a little bit more attention. We decided at the time not to adjust any from her medications, like to do like a TID metformin, but to keep, she really wanted to try to think about her diet a little more clearly in the presence of this. Oh no, my blood pressure is getting higher. It motivated her to have a little bit higher glycemic control. So we'll keep monitoring that and seeing how that goes and make sure if we don't need to make any adjustments in the future, maybe go TID metformin. And again, with that continued follow up, we just kept her on kind of like 3 months, a 3 month cycle, doing labs every 6 months with her to keep monitoring that blood pressure, her diabetes, and her lipid profile. Because this is a patient who is at risk, of course, for having some sort of cardiovascular issue. She's got several different microvascular issues here between the diabetes and the hyperlipidemia. And so we really want to keep tight control over those so we can prevent neuropathies, renal disease, any issues with wounds or healing. We're checking that constantly, as well as like heart attack, stroke, any of the bigger things as well. But eyes, she's got several different things that are pounding and putting pressure on all of her microvascular the body. So we have to keep monitoring her. So she's on it every 3 months. And that kind of wraps up Miss Johnson. That's an approach to when you have something normal. What do you do when a patient comes in and their blood pressure's creeping up? Um, really ruling out the red flags, making sure you're looking at everything, looking for end organ damage, looking for what other comorbid condition they have going on. How is it affecting their other conditions? The one that seems to be the problem right now. And looking at the patient as a whole holistically is very important. Not looking at diagnoses alone, but looking at multiple diagnoses, socioeconomics, all of that together will help you not miss things, especially red flags. Right. So our next patient is going to be, oh, do this patient first. Wrap back around. Yes. Okay. So this patient, this is Miss Mitchell. We have, of course, we're not using real patient name, things like that. Okay. But I like to give names to my presentation. So Miss Sarah Mitchell, she is 38 years old. She does not have any medical history. She's presenting to the primary care office. We've seen her a couple of times, mostly just for UTIs. She's had three children during the time while she's been with us as well. So then nothing much. We haven't really seen her much. Maybe every couple of years she pops in with a small complaint or for a wellness exam just to see how everything is. But her presenting complaint today is that she's presenting with fatigue. And fatigue is a very difficult one to work up. I think there's a lot that goes into working somebody up for fatigue. It can be an overwhelming thing because a lot of people deal with fatigue, and there's many reasons why someone could deal with fatigue and decreased energy. Some of the things you have to look at is timing. How long have they been feeling tired? What's the onset of it? Thinking of your PQRST, is there anything that seems to make you more fatigued? Is there any activity intolerance? Um, and just looking at all of those different things. So we ask the patient, how do they feel like they're sleeping? Do they feel like they're sleeping the whole night? Are they waking up? Are they tossing and turning? Can they not fall asleep? Can they not stay asleep? We're looking at psychological aspects, health concerns, lifestyle, everything in there. So this patient reports that she gets full night's sleep. She's not waking up. She's sleeping her regular hours of 10 p.m. to 6 a.m. And she does not feel like she's getting her energy back. Then we can rule out almost immediately there that there is an actual sleep disturbance other than we would want to still consider sleep apnea. This patient is young. I think she weighs like 125 pounds. She does not snore. So we're already ruling out quite a few things. If they're falling asleep and staying asleep, there's probably also not depression or anxiety because those are both kind of issues that will either make you not be able to fall asleep or makes you wake up early. Um, so we're ruling out those things, but we could do some evals there. Let's look at the patient's vitals. Blood pressure's fine, heart rate's fine, rest's good, oxygen's fine. So nothing going on with vitals. Vitals like 112 over 70, heart rate 78. Everything looks good. Again, she weighs about 125. She's 5'2", so petite. On physical examination, we're going to be looking for things like dysrhythmias. We're going to look for swelling. We're going to look for lots of signs and symptoms. So generally, she appears tired, no sign of acute distress, regular rate and rhythm, no murmurs, clear lungs, abdomen soft, non-tender, non-distended, no focal deficits, no odd distributions of body fat, nothing like that, no mood face, no changes in skin tone or color. Or we can get labs too. And so that's where you're going to be able to find a lot because you're going to do a physical exam with someone who's fatigued. And most of the time, you're not going to find anything specific. One thing that you might also want to consider is you want to palpate your thyroid. And this patient, her thyroid felt normal, but we would still really want to assess that because that is something very common. She's had three children. She's getting close to her 40s. She is Caucasian. She fits a lot of the check boxes for someone who might have hypothyroidism, but she has not had like an unexpected amount of weight gain ever recent. So that one would be on our differential list. We absolutely need to test those labs, but it's not going to be our highest one. So when we do our labs, what are we going to order? We're ordering the CBC, thyroid function. You can order a sleep study. I would recommend doing your labs first and then doing a sleep study later. Do your BMP as well, and you do liquids. So with this patient, when we went through and did her CBC, her hemoglobin was 10.5 and her MCD was 7.2. And so once you get that, frankly, for this patient, I didn't order the initial lab set. This patient, I would have gone ahead and just ordered an iron panel straight away. I'm looking at a young woman who's tired, who's been tired for 6 months, who menstruate. Let's look at the CBC and let's look at that iron panel. That's really high on my list. Also looking at vitamin D. You could look at the B vitamins, but that one I think would be the later one as well. So CBC, thyroid, iron panel, BMP. Later down the road, if nothing comes back positive there, we could look at a sleep study. What are our differential diagnoses here? Iron deficiency anemia, hypothyroidism, sleep apnea, and we ruled out hypothyroidism with the labs. We do have a low hemoglobin and a low MCD. We need to go back and do an iron deficiency or an iron panel. And that comes back. Yes, there is this low ferritin and low serum iron. So we're going to start the patient on ferrous sulfate 325, making sure they're taking that with vitamin C. You can also do slow FE. This patient's not remarkably low, but it is probably contributing to her fatigue. And the slow FE will have less GI side effects for that patient. Still taking that with vitamin C. Lifestyle modifications, making sure they're eating red meat, spinach, beans, lots of iron containing foods, even like bran flakes, anything that's been fortified. And look at their diet. And she was not eating a whole lot of meat. She was leaning more on the vegetarian side and was using things more like tofu as some of her protein replacement. So we just encouraged her to eat a lot more beans and have meat a couple of times a week. She wasn't opposed to it. She just hadn't really considered that that was could contribute to it. And she said, yeah, I could eat red meat a couple of times. Not excess, but definitely her appropriate more beans and spinach. And we followed up with the patient. How long do you wait after you start iron therapy? Or should you wait probably about 3 months? So in about 3 months, we can reassess her CDC. Even within the first 2 to 4 weeks, you can bring them back. Hers is not remarkably low, right? You can bring them back just to see if we're trending upwards. We're having just an upward trend, but really it takes 3 months to reestablish that. So I'd bring her back in 3 months at the maximum to reassess everything. They can always send a message via the portal, or they can just like little messages saying, hey, is it improved? Are we improving? Or are we still very fatigued? And we want to see that upward trend over that course of 3 months. If we're not seeing any improvements there, we need to start looking at other things in conjunction to the iron deficiency anemia. Why did you have iron deficiency anemia? Was it just because you're a female who wasn't eating enough and been straight? Or do you have an autoimmune condition that's been undiagnosed and you just haven't really assessed for something like anemia of cotton disease? So looking back at those things. Yeah. So I think that's how you take an approach to fatigue. There's many different little pathways that you can go down when it comes to fatigue. Rule out things like dysrhythmias, hypothyroidism, looking at the anemias, looking for obstructive sleep apnea. There's lots of reasons to be fatigued. Look for the normal ones first. If you can't find anything there, then you go in and look for some of the more zebra type things in the horns. But if you hear hoofbeats, start off with thinking it's a horse, as most of the time it will be. And then you can go back and start looking for some crazy things. And start with things that are least invasive. Like I am not ordering polysomnography on a 38-year-old female of normal body habitus straight away. No, I'm going to start with the things that are more likely: CDC, thyroid, BNP. All right, let me look at our last patient here. We can go over. So this is putting up this one's slightly obvious because of what we just talked about. So this patient is Emily Adams. She's a 35-year-old female presenting with fatigue, weight gain, cold intolerance. So you already know. But we can talk about what are some of the things that you want to look for in conjunction with that. So she's got fatigue, persistent fatigue, weight gain of 10 pounds over the past 2 months, and increased sensitivity to cold. She denies any significant changes in appetite or exercise. Blood pressure is 120/80, heart rate is 68. Blood pressure, or respiratory rate's fine, O2 is 100. On physical examination, she's tired, no distress. Of course, we're palpating that thyroid because we're already making thyroid with this type of patient, or maybe PCOS could be another consideration. Well, diabetes, you want to look at all those. No palpable thyroid enlargement or tenderness, regular rate and rhythm. Skin was dry. That was a big notice. And she said she felt like her hair was thinning. So again, we're leaning more and more thyroid, less and less towards something like diabetes or PCOS. Because we also looked at her arms. She didn't have a lot of hair in her arms, not a lot of hair here. So you're looking for that. Hirsutism that comes along with PCOS, not having any issues with her period. That's something important to assess. Not frequent urination, not very thirsty, not very hungry. So again, trying to rule out symptomatically all of these things related to unexpected weight gain, presenting coupled with fatigue. Okay, we've symptomatically ruled out diabetes and PCOS, but let's look at the labs. I would go ahead and check her sugar. Could just do a finger stick, and then also checking thyroid. And just looking at those two things real quick before we're probably not going to jump into PCOS much unless I found something on her finger stick or CBC, or sorry, A1C. Good thyroid function tests. As expected, the TSH was 12 and free T4 was 0.8. So we're going to go ahead and say, yes, this is related to hypothyroidism. We, of course, would want to make sure that we had considered those other things as well. And the same things that we considered with the previous patient. Is there depression? Is there any anemias, things like that, which can quickly rule that with a CBC. CBC was normal, thyroid function abnormal, A1C was normal. So we're on our way to our diagnosis. We've got primary hypothyroidism. What are we going to diagnose? We're going to start them off on levothyroxine, 50 micrograms a day. Make sure they're taking it on an empty stomach before any of their other medications. And definitely want to discuss this patient, the importance of consistent adherence to this medication. If they're not taking it consistently and not taking it as prescribed, they're going to continue with their weight gain and fatigue. You have to replace that thyroid hormone every single day, or it's not there. Some patients have a difficult time finding their dose, so to speak, but we need to follow up with them in 6 weeks to recheck their thyroid function test and to assess for their symptoms because we have a little wiggle room there. Even if the TSH is normal, you want to know how normal is it, how within that range is it, and see if the patient would benefit from a higher dose. And making sure they don't have any symptoms of tachycardia, like we haven't overdosed them and they need a smaller dose. So again, a lot of times I teach pharmacology. And so when you see a medication, side effects typically come from it working too well. If the dose is too high for that patient, they'll have symptoms of hyperthyroidism. That would be something that you would want to address or follow up again. With that 6 week follow up, you're repeating the thyroid function test and you're assessing for continued signs of hypothyroidism or new signs of things that look more like hyperthyroidism. So when this patient followed up with us after 6 weeks, she said there was a remarkable increase in her energy levels. She's only lost 1 or 2 pounds. She's working on that. And is hopeful too, because now she has a medical reason and she can work within that. Her TSH is 3.5, free T4 was 1.2. So we had appropriate thyroid hormone replacement symptomatically and from a lab perspective. Now we're going to see her every 3 to 6 months. And then after that, we can move her to 6 months to a year if she stays stable and it doesn't need change in dose. With the caveat of, hey, if you start feeling very much you're having these same symptoms over again, schedule an extra visit with us so that we can just get that checked. And you can just order labs and send them to the lab and just get the labs done with you. There's so much you can do without bringing the patient fully into your office, which is so important when you're holding a full patient panel all by yourself. Making sure that you're utilizing your time well, getting the patient addressed as soon as possible. A lot of stuff can be handled over message. So do as much of that as you can. Be diligent with that and let them know that they can do that so they're not having to think they have to schedule an appointment every time.